Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
You know, it's actually pretty amazing when you stop and think about it.
What's that?
Well, some of these core medical procedures, the tools we really rely on, they've been around for decades. But they're just constantly evolving, aren't they? Getting smarter, safer.
Absolutely. And sometimes even starting to blur the lines with completely different areas of medicine.
Exactly. It's not just about the procedure itself anymore. It feels like this incredible blend of, technique, really cutting-edge tech, and, of course, patient care.
That's a great way to put it. And today we're taking one of those deep explorations into, modern colonoscopy.
Right.
We're going beyond just the basics, looking at how this really established diagnostic tool is still pushing boundaries, especially how it sort of bridges the gap between endoscopic and surgical approaches.
So our mission here in this deep dive is to unpack the key insights from a specialized medical understanding. Yeah. We want to reveal how something so fundamental like a colonoscopy keeps innovating.
Yeah, covering the why, the how, the safety.
Exactly. We'll look at its crucial uses, the really vital safety steps now in place, the fascinating skill involved, in actually doing the procedure.
And even some surprising debates around it, too.
Right. The aim is really to give you a clearer picture, maybe offer some of those aha moments that make complex medical stuff feel, accessible and genuinely interesting.
Okay, so let's get into it. Let's unpack this journey.
Let's start right back at the beginning. Flexible endoscopy of the colon. That first appeared in 1963, right?
That's right, 1963. And it really has come an incredibly long way since then.
Hasn't it just?
From that initial introduction, it's just consistently evolved. It's now what we absolutely consider the gold standard diagnostic test for looking at any disease in the colon.
Gold standard.
And what's really striking, I think, is that the improvements, both in technique and, the actual scope technology, they haven't just made diagnosis better. They've also led to these huge leaps in what we can do therapeutically during the procedure.
So fixing things, not just looking.
Exactly. And that's precisely where you see that boundary between endoscopy and surgery getting, increasingly blurred.
Interesting.
So for anyone performing these procedures, a really deep understanding of both the sort of art of the technique and the technology behind it is absolutely fundamental for high-quality, safe care.
Okay, so thinking about that decision-making, when does a doctor, decide a colonoscopy is really the best way forward for a patient? What's that process like?
Well, it always begins with carefully weighing up the risks versus the potential benefits for that specific person.
Makes sense.
For instance, a full diagnostic colonoscopy, it's very thorough, but it does carry maybe a slightly higher risk from things like the sedation needed, the bowel prep,
right,
compared to, say, just a diagnostic flexible sigmoidoscopy that just looks at the lower part of the colon.
And that's different how?
Well, a flex sig, as we call it, is usually quicker, often cheaper, generally easier to do, and lower risk because you might not even need sedation. But interestingly, sometimes finding an issue down low with the sigmoidoscopy can actually be a sign, a marker, that there might be problems further up.
So it could lead to a full colonoscopy anyway.
Often, yes. If we see certain things distally, it prompts a discussion about needing the full view offered by colonoscopy.
Got it. And what about the other side of that? When is a colonoscopy definitely not the right move?
That's a really critical point for patient safety. There are very clear situations where it's what we call contraindicated.
Okay.
The only absolute no-goes are, one, if a patient who's fully able to decide simply doesn't consent, doesn't want it,
Correct.
or two, if there's a known confirmed perforation, a hole in the colon, that's an absolute contraindication.
Right, definitely not that.
Beyond those, we have what are called relative contraindications. These are times you'd be extremely cautious.
Like what?
Things like an acute flare-up of diverticulitis, or immediately after major surgery, a very recent heart attack, say within the last month, or a recent blood clot in the lung, an acute pulmonary embolism. Also, severe problems with blood clotting, especially if you're planning to do something therapeutic like remove a polyp.
Right, because of bleeding risk.
Precisely. Or if the patient's vital signs are just unstable, what we call hemodynamic instability.
Are there any other sort of special cases?
Yeah, a couple. For instance, in severe inflammation of the whole colon, fulminant colitis, a limited exam just to see how bad it is and get some biopsies might still be helpful, even though it's risky.
Okay.
And for pregnant patients, while colonoscopy is generally seen as safe, it's really reserved only for very strong reasons and always needs careful discussion and coordination with their obstetrician.
So it all comes down to that careful balancing act.
It really does. It underscores that balanced medical teams are constantly maintaining to keep you safe.
That makes perfect sense. And speaking of safety, something seemingly simple but incredibly powerful in medicine, especially surgery, is the checklist.
Ah, yes. The humble checklist.
Because they play a role in endoscopy too?
Oh, absolutely. It's one of those insights that feels almost obvious once you see the impact. Checklists are now pretty standard, often mandatory, in many endoscopy units.
Why is that?
For a very simple yet profound reason. They dramatically help prevent errors. Just like in the operating room, they have a real, tangible, positive effect on reducing patient complications, morbidity, and even mortality.
Wow.
It's such a straightforward tool, but you really can't overstate its influence on safety.
Okay, now here's where things seem to get, really interesting. There's this ongoing debate about sedation during colonoscopy, different ways to keep patients comfortable.
Absolutely. It's definitely a nuanced discussion, not clear-cut at all.
How so?
Well, there was a large study across multiple European centers. It found most colonoscopies used moderate sedation or conscious sedation. That's where you're relaxed but still sort of responsive.
Okay.
Now, deep sedation, where you're low and responsive, was linked to slightly shorter procedure times and maybe fewer technical difficulties.
Right.
But it also needed more resources, staff, monitoring, and actually led to more hospitalizations for complications afterwards.
Oh, interesting. More complications.
Well, more hospitalizations for complications, yeah. So, based partly on things like that, the American Society of Gastrointestinal Endoscopy, the ASGE, concluded that they couldn't really endorse routine deep sedation for just average risk patients.
Okay, so the U.S. stance is more cautious on deep sedation for everyone.
Generally, yes. But then you contrast that with, say, a British position statement, which actually noted an increasing need for deep sedation and even general anesthesia.
An increasing need. Why?
Because the complexity of the procedures being done endoscopically is growing. More therapeutic work, longer procedures, trickier cases.
So definitely not a one-size-fits-all situation,
Sure.
and different philosophies driving it.
Not at all. And think about flexible sigmoidoscopy again, just the lower colon exam.
Yeah.
That's most often done completely unstated because adding Rives sedation would kind of negate its benefits, the quickness, the ease. And it's important to remember that unsedated colonoscopy is also entirely possible. Research shows it can be done with very few complications and actually pretty good patient acceptance.
Really? Unsedated?
Yes, though it's not for everyone, obviously. For those who need a bit of help but maybe not full sedation, there's nitrous oxide, Entonox, gas, and air.
Like women use in labor?
Exactly like that. It can be a useful, short-acting, reversible aid. Quick in, quick out.
Sounds good. Are there downsides?
Well, there's a cost implication, obviously. And a growing concern is actually its environmental impact.
Environmental.
Nitrous oxide.
Yeah, it turns out it's about 300 times more potent as a greenhouse gas than carbon dioxide. So that's becoming part of the conversation too.
Wow, I hadn't considered that.
And really crucially, research keeps highlighting that there are still avoidable complications, even deaths, linked to sedation across the board.
Avoidable.
Yes. Which has led to really strong recommendations now for proper, formal, competency-based training for everyone involved in giving sedation during these procedures. Not just the doctors, but nurses too. That seems essential.
It really highlights all these interconnected factors, doesn't it? Patient comfort, procedure efficiency, cost, safety, training, even environmental impact. It's complex.
That really is a lot to weigh up.
Yeah.
Okay, let's shift gears a bit. From the why and when to the how, the actual hands-on skill, I imagine even among experts there's some variation. But what are the sort of fundamental principles for doing a colonoscopy safely and efficiently?
You're right. There's variation, but definitely core principles. And it is quite an art navigating the scope.
I bet.
Most skilled endoscopists these days tend to favor what's called a one-person single-handed approach.
Yeah.
Meaning one hand, usually the right, is focused in manipulating the long shaft of the scope, pushing, pulling, twisting.
Okay.
While the other hand, the left, operates the controls on the handle that angle the tip.
Ah, the steering wheel, essentially.
Kind of, yeah. You've got a large wheel for up-down angulation of the tip, and then you use your right hand to apply torque, that twisting motion, to the whole scope shaft to help steer it sideways. There's also a smaller wheel for left-right tip angulation, but that's mainly just used to keep the view centered while you're applying torque.
Got it. So how does it start? What are the very first steps?
Well, even before the scope goes in, a digital rectal examination is always done.
Why is that?
Two main reasons. Lubrication, obviously, but also to feel for any problems right at the very end of the bowel that the scope might miss initially.
Okay.
Then the actual insertion into the anus should always be done under direct vision watching through the camera.
Right.
Initially, you might just see a red out where the camera's right up against the bowel wall.
Just pink.
Yeah, exactly. So to get your bearings, to find the lumen, the pathway forward, you use a little puff of air or gas.
Insufflation.
Right, gentle insufflation. You might pull back just a tiny bit and use small movements of the tip controls. That usually opens up the view.
And then you're on your way.
Pretty much. Oh, and one other thing often done right at the start is rectal retroflexion.
Which is?
That's where you carefully bend the tip right back on itself to look backwards at the very last section of the rectum. It's often best done early on to spot anything hiding down there.
Makes sense. So moving beyond the basics, what are some of those maybe advanced strategies or core principles that really skilled endoscopists rely on to make the journey through the colon smoother and safer?
Ah, yes. This is where the real nuances of technique come in. Probably the most important one, often called the first rule of good colonoscopy, is pull back more, push in less.
Pull back more. That sounds completely counterintuitive. You're trying to go forward.
I know, right? But it's absolutely vital. Pulling back frequently helps keep the shaft of the scope as straight as possible.
And why is a straight shaft so important?
Well, a straight shaft gives you much more precise control over where the tip is going. It prevents stretching the mesentery, that tissue holding the bowel.
Right, you mentioned that causes discomfort.
Exactly. Stretching causes pain. Pulling back also effectively shortens the colon by pleating it over the scope, like collapsing an accordion or a concertina.
Ah, the concertina effect.
Precisely. So pulling back helps smooth out sharp bends. It can disimpact the scope tip if it gets stuck against the wall, and it generally improves your view.
And the danger of just pushing too much.
Big, unstable loops forming in the scope shaft inside the patient, which causes more pain. You lose that one-to-one control between your hand movements and the tip movement.
Sounds risky.
And it definitely increases the risk of iatrogenic perforation accidentally making a hole in the bowel. So pull back more, push in less. It's key.
Okay, rule 1. What else?
Rule 2, maybe? Use torque frequently.
Torque, that's the twisting motion you mentioned.
Exactly. Twisting the scope shaft clockwise or anti-clockwise with your right hand.
What does that achieve?
When the shaft is relatively straight and the tip is angled, applying torque gives you sideways movement at the tip. It also helps to stiffen the scope shaft somewhat.
Why stiffen it?
To resist forming those loops when you do need to advance, it helps maintain that straight path.
I see.
And torque is also crucial for getting rid of loops if they do form. There are different types: end loops, alpha loops, reverse loops. But the principle is using the right direction of twist combined with pulling back to straighten things out.
Fascinating. Like solving a puzzle inside the colon.
A little bit, yes. Okay, another key principle: minimize insufflation.
That's the air or gas you put in.
Right. Too much gas is a really common cause of pain or discomfort because it stretches the bowel wall.
Makes sense.
And there's also that small risk of pneumatic perforation, a hole caused by too much pressure, especially over on the right side of the colon where the wall is thinner.
So less is more with the air.
Definitely. Frequent suctioning of the gas not only prevents discomfort, but can actually help the scope move forward because of that concertina effect again. As you suck air out, the bowel collapses down onto the scope.
Clever.
And as we touched on with sedation, the type of gas matters. Carbon dioxide is now widely recommended over just room air.
Why is that?
Because CO2 gets absorbed by the body much, much faster. So patients have significantly less bloating and discomfort after the procedure.
Good to know. Any other alternatives to gas?
Yes, water-aided colonoscopy is gaining ground, using water instead of air or gas.
How does that work?
Two main ways. Water immersion, where you fill the segment you're in with water, or water exchange, where you continuously suction out dirty water and instill clean water.
And the benefit?
It's often advocated for better patient comfort scores, and some studies suggest it might even improve the adenoma detection rate, finding those precancerous polyps.
Interesting. Okay, what's the last major strategy?
A simple but often very effective one: patient position change.
Just moving the patient.
Exactly. If you move the patient, say, from lying on their left side over towards their back, or even onto their right side during insertion or withdrawal,
What does that do?
it uses gravity. It can shift fluid away from the area you're trying to see and allow gas to rise into the uppermost part of the bowel segment.
So less suctioning, less puffing air in.
Right. It can also give you a mechanical advantage, helping to open up some of those tight corners, like the term from the rectum into the sigmoid colon or the big bends near the spleen and liver, the splenic and hepatic flexures.
Gravity helps straighten the path.
In many cases, yes. It's a simple technique, easy to learn, and studies show it helps the scope advance in maybe 2/3 of difficult cases.
Are there limitations?
Well, it needs the patient to cooperate, obviously, so it can be tricky if someone's heavily sedated or under general anesthesia.
Right.
And there's a specific point for water-aided colonoscopy. If you're using water immersion or exchange, you typically keep the patient on their left side while navigating the left colon.
Why is that?
Because the water itself actually helps weigh down the sigmoid colon, which can minimize loop formation in that tricky area.
Huh. So many factors to consider.
Absolutely. These are the kinds of practical, quite nuanced techniques that really make a difference in the skill of the procedure. It gives you real insight into the expertise involved.
What an absolutely incredible deep dive into modern colonoscopy. Seriously, we've covered so much ground, from its evolution to becoming the gold standard.
And the crucial reasons for doing it.
Right, the indications, the contraindications, the vital role of those safety checklists,
Can't forget those.
and that really fascinating ongoing debate around sedation. So many angles there.
Comfort, efficiency, risk, environment.
Yeah. And finally, exploring the art and science of the procedure itself. Those really meticulous techniques that skilled endoscopists use for a smooth, safe journey through the colon.
It really does underscore how much goes into what many might just think of as a routine procedure and just how much it continues to evolve.
Absolutely.
Yeah.
So as you listening reflect on all this, maybe consider this thought. What might the next decade even hold for these kinds of endoscopic procedures, especially with that constant blurring of the lines we talked about between diagnostics therapy and traditional surgery?
It's an exciting question.
It really is. And hopefully understanding these kinds of intricate details helps empower you, to engage more deeply with your own health decisions, or maybe just appreciate the incredible ongoing advancements happening in medicine all the time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.